Perfect. Now it's official. We're starting off the discussion. So my name is Miss Lizzie Otai, as I mentioned earlier on. I'm the communications consultant for ENASO, and we're going to have an engagement for half an hour, 1.5 hours, talking about community engagement in pandemic prevention and one. Of course, this particular call would have not been possible without our partners. As ENASO, we believe in collaboration, and we appreciate our partners for making this particular discussion happen today. So we extend our thank you and gratitude to Prezod, CIRAD, ILRI, and of course, the Anglophone Hub that's being hosted by ENASO. So welcome all. Next slide, please. As ENASO, we just want to let you know there are a couple of the fact that you've actually registered for this particular webinar means you've given consent to have the session being recorded. Please have yourself on mute at all times. I know the way we've set up the Zoom is once you get into the call, you're automatically unmuted. So please have yourself muted. You can subscribe to our newsletters, and those details will be shared later on as the discussions and deliberations are ongoing. But if you've gotten a direct link, you can please rename your account. We want to know who's on the call so we can refer to you correctly. So you can rename your account to your name or your organization. Use the chat option. We like engaging. We want to know who's in the room. So do type your name, your organization, and let's engage all through. I know we have communities and civil societies, but we also encourage for each other to respect each other's input. So when somebody is speaking, please do give them their time, and you can have your chance to respond or even give a comment to it. We always want you to have fun because it's communities. We do things a bit differently, but on top of it all, we like you to network. Next slide. So we do have a couple of speakers who are going to address us today. We'll start off by just getting to understand pandemic prevention and the One Health concept. And we have Marisa Perry, who's also on the call. Thank you, Marisa, for joining. Marisa is an epidemiologist and Deputy Director of ACE-TRE at CIRAD, and we'll get to know more about CIRAD and what they do, specializing in health surveillance systems and emerging zoonotic risks. She does have a heavy portfolio. I tried to summarize it, and I'm hoping I'm doing justice to it, Marisa. So she works with international organizations like FAO, the Pandemic Fund, the World Bank, and the World Organization for Animal Health. So welcome very much, Marisa, on the call. And as a co-founder and science leader of PREZOD Initiative, so PREZOD is an abbreviation, so that's Preventing Zoonotic Disease Emergence. She advocates for a bottom-up approach to health risk prevention worldwide. And as CSOs, we understand and appreciate the bottom-up approach. So welcome very much, Marisa. We will also have Bernard Brett on the call. And as I mentioned earlier on, I'm just giving you a snippet because their portfolios are pretty heavy. Bernard Brett is an infectious disease epidemiologist and a team leader of the One Health Center in Africa at the International Livestock Research Institute, also one of the partners based in Kenya. So his work focuses on the transmission patterns of zoonotic diseases and implementing applied research and capacity building initiatives across East Africa, of course, and West Africa. He's passionate about strengthening One Health capacities, and Bernard has been actively involved in training national and subnational officials in these regions. He holds a PhD in veterinary epidemiology from the University of Nairobi. I will get to put a face to this brief bios as the discussions are ongoing. But we'll also come to hear from Professor Musso, who's also on the call already, a veterinarian researcher, a lecturer in veterinary public health, ecological public health, and wildlife medicine. And I'll be honest, most of the terms I'm using I also do not understand, but as the discussions go on, we'll get to kind of get more emphasis on what they do. So he serves as the One Health coordinator for the World Bank's Africa Center of Excellence for Infectious Diseases of humans and animals, as well as the COHESA project. And COHESA is also an abbreviation for Capacitating One Health in Eastern and Southern Africa. So we do have a rich background of speakers who really do have a niche when it comes to One Health and health in general. And we're hoping also we'll get Alexander Caron on the call. He's a researcher at CIRAD, and CIRAD is also one of the partners for this particular engagement. He's a visiting scientist at ILRI and the PREZOD focal point in Kenya. Ladies and gentlemen, as I mentioned, automatically you're getting on the call and you're unmuted. So please, if the team can also help and just mute, that would be awesome. Thank you very much. So there's 4 speakers are going to speak to us around today's topic. So we're looking at pandemic prevention, but we're also looking at One Health. But ladies and gentlemen, just to emphasize as we go, we believe in collaboration. And if you want for us to engage further on a national level, feel free to reach out to the team and to the partners on the call. Use the chat box and we can have national discussions. I know Prasad, Sherad, Ayla, Rai, Yena, so we're more than happy to start having country discussions as we go. Next slide, please. Now, without further ado, let's get into the discussions, and we want to bring in Marisa to just give us a snippet around introduction of One Health, pandemic prevention, community-based surveillance, and of course, what does President do? Marisa, if you're on the call, please feel free to unmute yourself. And I hope I didn't butcher your last name. I'm bad with names. But over to you. Take it over.
Thank you very much, Lydie, for this very nice introduction. It's a real pleasure for us to be here, for me and for us to be here and to take part of this webinar. As you mentioned, so with Presod, we've been advocating for more engagement and inclusion of communities in decision-making and strategic thinking. So this is a great opportunity for us. So Presod, as you said, stands for Preventing Zoonotic Disease Emergence. And the idea is really to fight the risk in the grounds before they become a pandemic issue. So why is it important? Because we know that the vast majority of infectious diseases that are currently circulating in humans are from animal origin, 75%. And there is a risk and increasing risk of new emergence. And the 60% of the new emerging diseases are originating from animals. And this is linked with the increased contact between animal, human interface, including wildlife, but also intensive breeding and domestic animals. Next slide, please. So this risk has been increasing in numbers and frequency over the past 50 years, and we've seen it from the first SARS-CoV pandemic spread in early 2000. Then we had the influenza H1N1 pandemic spread in 2009, which was emerging at the same time as there was a zoonotic pandemic of avian influenza H5N1 over the world from 2003. We've also experimented the Ebola spread in 2013, 2014. And as I said, there's this circulation of zoonotic influenza, which could be a risk for pandemic disease, such as H5N1, but also H7N9. And we know that with this connected world, there is a risk when a disease emerges somewhere that it's quickly spread everywhere. Next slide, please. And of course, we have experimented that very recently with the COVID-19 pandemics, which resulted cumulatively to more than 15 million deaths, which is close to the Spanish flu, the 1914 pandemic flu in the early 20th century. Next slide, please. So this is a very complex issue which links animals, human, and environments. And these issues needs to be tackled with a collaborative and intersectoral approach, which is called One Health. So what is One Health? One Health's concept is recognizing that the health of humans, the health of animals, and the health of environment is interlinked. So everything we do in the human sector will have an impact in the animal and environment sector, and vice versa, including action that we might be doing to protect humans. For example, if we want to limit the emergence of pandemics, we might want to limit the consumption and the circulation of and the contact with wildlife. However, wildlife consumption in some area of the world represents the only source of proteins, and so preventing the use of wildlife consumption will have an impact on food security and nutrition. And this has to be taken into account. So we need to acknowledge this different impacts in the different sectors and be able to work all together to be able to tackle this issue. The other aspect which is very important in pandemic prevention, so it's the intersectoral collaboration, but also this bottom-up approach, because we know that the animals are spreading disease, and this is emerging at the very local level. So we need to work with the people that are at the front side of risk, which are the communities. And we need to make sure that the action that will be implemented to protect the health of the people will be relevant and acceptable for the people that will be implementing it at the community level before they become entrenched into national and international policies. So PRESOD is promoting this change in paradigm towards prevention in a bottom-up approach, while still ensuring food security and livelihood of the poorest community, and that is very important to highlight. Next slide, please. So as I just said, communities are at the front foot of pandemic prevention, and what we have seen from science and scientific work in the past 20 years is that they are not acknowledged as the key elements, especially in the surveillance chain. And you will see a short video explaining that at the end of my presentation. Next slide, please. So as I mentioned, within PRESOD, what we are looking at is really the prevention aspect of the pandemic issue, which is looking at the interconnection between animal, including wildlife and domestic environments, pathogen and host, which are the humans. And this is what we call the pre-emergence stage. And that is including what's all the impact on global changes and the impact on humans on nature, including agricultural practices, land use practices, etc. And we are also looking at the interface between animal, humans, and environment, where the spillover is happening before the disease becomes human and starts spreading between humans and becoming a pandemic. And this is where we need to act, and this is where the community play a very important role in the pre-emergence and the spillover stage. Next slide, please. So how do we promote that, and how do we do that? So we have worked with the international community worldwide in the past few years, working with different type of factors, including NGOs, community representative, but also scientists, academics, research institutes, and government representative in all over the world through 27 international workshops, including more than 1,500 participants, to be able to build the scientific framework and the operational plan on how to put this into action. And we came up with 5 different pillars to be able to tackle this emergence risk. The first one is looking at the risk. What are the zoonotic risks and the practices? So who is doing what that is promoting the risk, including local actions, but also global actions. The pillar 2 is about working with all these people, co-designing solutions to reduce those risks. And as I mentioned before, with the wildlife consumption, we can't just ban it. We have to find alternative. We have to understand the practices and work with the people that are implementing this practice to ensure that they can still sustain in terms of food safety and livelihood if they change their practices. So this is working in participatory approach to co-design those solutions. The third pillar is about really detecting early the first sign of emergence, and that is by strengthening the early warning systems, especially at the community level. So this is really this community-based surveillance, where the idea is to work together between animal, human, and environment specialists, but also the community, to be able to see first sign of disease emergence in animals, in the environment, and in the humans, and to take quick actions to be able to prevent it before it becomes a national and international problem. Of course, this is very important that this information is shared, at least to be able to promote these actions in different countries and all over the world. So to learn lessons, and this is what Pillar 4 is all about, to be able to share the good practices, to share how countries are tackling these issues at the local level, and to share it at the international level so it can be advocated for. And Pillar 5, which you can see, is the baseline of all this work. It's the cross-cutting pillar. It's all about stakeholder engagement and co-design of health policy, One Health policy, meaning that we are promoting the voice of the communities in the design of the policy itself at the government level, because working at the local level in a bottom-up approach is very important, but we also need to make sure that the actions that will work in the field be sustainable, and to be sustainable, they need to be embedded into the national and international policy, and this is definitely not happening enough. Next slide, please. You will see at the end of my presentation a short video which will explain a bit more how PRESOD was launched. I just want to mention here that this is a science-led initiative that is already it's a coalition of partners, so we have got more than 250 international institutions, which is a partner of PRESOD worldwide, and that includes NGOs, that includes research institutes, that include government organizations, and including the partners of the webinar today, ILRI and the University of Zambia. And so we work all together to be able to promote this change in paradigm, and we also engage countries politically. So PRESOD has been supported at a very high level politically, and this gives us a voice that we never had as scientists working on the emergence. And we can also use this voice to make the voice of the communities more heard and more visible. So we engage countries politically, as I said, and we already have 27 governments engaged in the initiative, and we are still advocating for more to be engaged. And that is to be able to address what I've said before, to make sure that everything we're going to do at the local level will be embedded into national policies. Next slide, please. So what we aim to do, as I said, we are a science-led initiative, so we want to build common scientific framework, and as I mentioned with the different pillars, to be able to implement and coordinate not only research projects, but also improve surveillance system and develop operational projects to maximize their impact. So the coordination aspect is very important, because we've seen in the past 20 years a lot of action, a lot of funding, but very fragmented, very disaggregated, and a lot of action and solutions that were born at the local level, and that was never made visible, and that would never take off at a more national and international level. So this is working together to maximize impact. Of course, we want to share those data, so building up a platform for that. And as I mentioned, we really need to keep on engaging with countries and decision makers. So PRESOD wants to become a resource center to be able to promote this change in paradigm. So everything we do is co-designed with the entire communities, involving civil society and other key actors, as I mentioned. And you could find all this information on the PRESOD website, including the scientific strategic agenda. Next slide, please. As I mentioned, I was ahead of my presentation. So we are a community of more than 250 members, which includes 27 countries. And you can see the countries. There is a lot of countries from Africa, but also from Asia and Europe and Latin America. And all our members represent more than 80 countries worldwide at the moment. Next slide, please. We have launched first actions in the field. Of course, there is actions that PRESOD is directly supporting and funding, and there is actions that are implementing by all our members. So action has started 20 years ago, and we're just making sure that we can promote it through PRESOD. But additional concrete actions that we can fund and we have funded are started in 2023. We have a big program which is PRESOD in Action in the Global South. And this is, you're going to hear today about some example of similar type of actions that PRESOD is supporting or PRESOD members are implementing. Next slide, please. And this is it for me, and I will leave you with the short video on what we are doing for promoting community-based surveillance and understanding a bit more what PRESOD is. Thanks a lot.
Great. Thank you very much, Marisa, for that. I know it takes a bit of time if you're given 15 minutes to make a presentation, but that was quite intensive. And ladies and gentlemen, we're discussing pandemic prevention and One Health, and we're look at community engagement. Now, we're going to play the videos real quick so that we can actually get to understand what PRESOD does and also what One Health is. So let me just play that video.
This morning, Yep, a poultry farmer in Bacnin, found dead hens in her yard. The others look sick too. Niambo, a forestry worker in Lesterville, feels feverish since he went into the forest to check on sick monkeys. Sophia is shocked when she discovers her sheep's dying next to the little river close to her farm. Community members are the first to be affected by any health event. They are the starting point and major actors of the health surveillance chain. They report their issues to the local specialists, who refer to their supervisors to get the laboratory team to investigate and seek for the cause of the disease and alert higher authorities. We often think of surveillance as experts looking actively for viruses. This is indeed important, but not sufficient. It doesn't allow the fast detection of the first signs of zoonosis, a disease transmitted from animals to human that can turn into a pandemic. With the community surveillance, we can detect fast enough alarming situations and implement useful actions. That's why their members have to be considered as part of the surveillance chain. We also need to engage back in reporting and responding fast to contain any health event as soon as they face it. We need to support their engagement by listening to their needs and constraints and create a win-win partnership. With the technology and research available today, it's possible to provide community members the information they need and get them to report in real time the events they are facing. Effective prevention of diseases and contamination requires sharing of information in real time at all levels amongst all actors, including the community. This is in line with the One Health approach, which calls for collaboration across human, animal, and environmental health. The community members are an essential part of it. Support science-based solutions with the PRESOD initiative.
That was this fast video, but we really are also curious to know, what does PRESOD do? And this is going to be like a very short video, just giving that brief.
PRESOD is an international collaborative initiative that aims to enhance the prevention, early detection, and resilience to rapidly respond to emerging infectious diseases of animal origin that can turn into pandemics. PRESOD strives for broad international coordination and has already brought together a global multi-actor community of more than 230 members, including research institutes, academics, NGOs, and 25 governments. Prevention is the most cost-effective way to avoid pandemics. Its effectiveness is ensured through science-society policy dialogues, bottom-up approaches, and collaborative surveillance with people at the front line of risk. By being the closest to the living scene, local communities are playing a major role in detecting and reporting unusual sanitary events as soon as they occur. PRESOD is based on the One Health concept, which integrates human, animal, and ecosystem health. In 2023, we launched 10 in-country projects in the Global South and an open call for projects in Europe for a total engagement of 60 million euros. We have also built on our members' existing operational projects and expertise and set up an operational governance of the initiative. With the Paris Peace Forum Scale Up program, the number of PRISOD members multiplied by 1.5 in 1 year. We engaged with new international stakeholders to strengthen our actions. We enhanced our collaboration with international health organizations through current or in-progress high-level working groups. Our visibility and positioning as an international scientific framework for pandemic prevention were increased, with reference to PRISOD in various high political platforms.
Thank you very much for that presentation and of course for sharing these videos. And ladies and gentlemen, we've just had Marisa give us a snippet of the One Health agenda. And ideally, we just want to figure out where does communities fit and what is the role of communities when we're talking about pandemic prevention and the One Health approach. Now, we are getting to a 5-minute Q&A just to get a bit of engagement with Marisa. And of course, I'll throw it out there, Marisa, if people want to work directly with you or engage directly with PRISOD. I mean, you're doing a lot of work. And what I also appreciate is the fact that you're looking at the preventative aspect of it. How can they reach out to PRISOD?
So they can contact us directly, where we have a contact address that Karine can share on the chat. Of course, we can give you all this information. If so, you can become a member of PRISOD as an institution. We engage with the institutions, but you like local institution, NGO. It doesn't have to be like a formal national institution. We don't engage with individuals only. You have to be part of a group, an institution. And it's very easy. So we have made it very easy for ensuring the more collaboration possible. We have built up a letter of intent, which just states the scientific postulate basis of what PRISOD has been built from, and the values that we all want to share and promote together, which is including engaging more with communities, promoting the One Health approach, ensuring public-private partnerships that are done in good practices, etc. So we have a list of values on this letter of intent, and this letter does not engage legally, nor financially, nor contractually, but it just states that as an institution or as a government, because government are signing the same letters, you agree to promote those values together. So we can send you all this information, and you can just apply to become a member.
Perfect. That is good to know. And also, we're just talking about communities' role, and you keep on saying the bottom-up approach, which really works because that puts the communities at the center and they get engaged a little bit early before it becomes to a full-blown epidemic or a pandemic. Are there any challenges when you're trying to engage in getting, governments, communities in one room and saying, you know what, we need to work together because you keep on saying collaboration? What are some of the challenges that you're facing? And we've seen this with COVID-19 when the vaccines were there, it was hard to get the communities to pick them up because they were not engaged at the beginning, but more of seen as, somebody who benefits from the vaccines and not the whole process of manufacturing and prevention and etc. So what are the kind of challenges and how are you maneuvering around those kind of challenges?
Yes, as you said, what we've seen, and we've seen it in every country of the world, including in France, when you don't engage people in the solutions, in thinking and making up the solutions before asking them to do something, then you face that. You face that acceptability would be very low. And we've experienced it with surveillance of animal disease and at the One Health interface over the past 20 years. So the challenges that we see is that the governments at the national level have not recognized until now, and this is changing. They've been considering communities as the source of data or as the beneficiary of the response, but not as a key actor to define the strategy. And what we have seen on the other side of the coin is that communities and actors in the field, including technical agents from the governments, from the different sectors, they were not implementing the strategies that were defined at the national level for surveillance, or if you have avian influenza outbreak, one of the control measures is to kill all the animals. And at some point, they stopped implementing it and they stopped reporting the disease because it was absolutely not rational for them. They would lose all their livelihood incomes. There was a psychological issues, and all of these elements were not taken into account. So basically, you have on one hand a policy which is made on paper because thinking this is the best thing to do by the government and thinking this is for the benefit of the people. And you've got the people that cannot implement this policy because it's just threaten their livelihoods because they are not being taken into account. The rest is not being taken into account, food security, education, all these things. So this is what we are facing, and what we are doing to be able to break this misunderstanding is to have everybody sitting at the same table, and also the scientists bringing up the constraints and the challenges that are the community facing, and also the national governments and the policy actors bringing up their challenges. They all have challenges, and it's a question of listening to each other and understanding role, responsibility, and constraint, and finding the best solution, which might not be the best solution epidemiologically, and we've kept on saying that to governments, but if the best solution in terms of health strategy does not work, then you don't do anything. It's like throwing money out of the window. So that's what we are promoting.
For sure, definitely. Thank you very much. And Marisa, please do stay on the line. I've seen a question on the chat, but we have to keep on moving on. And of course, at the end, we'll also do another general round of questions. So thank you very much for that. Ladies and gentlemen, welcome to today's discussion being hosted by ENASO, of course, in collaboration with Prezod, CIRAD, and ILRI, and of course, through the Anglophone Learning Hub that ENASO is hosting. We're talking about pandemic prevention and One Health. And we're going to go to our next topic, which we're looking at facilitating community participation on Rift Valley fever surveillance and control. And of course, we're going to look at it from the case study of Kenya. Now I'm going to call on over to Bernard Bett. Bernard, I saw you on the call. I hope you're there.
Yes, I'm still there.
Perfect, good. Now, Bernard, over to you. Just kind of give us more snippet and inside intel on what's happening in Kenya and key lessons that are coming out. So over to you.
Right. So thanks. I thank the organizers for inviting us to participate in this discussion. Of course, my name is Bernard Bett. I work with the International Livestock Research Institute, and I lead this project, which is being funded by BMZ from Germany, which does lots of things, including control of zoonotic diseases. But we have other pillars, other activities on food safety, AMR, but for today, we're just focusing on zoonotic Rift Valley fever. So let's go to the next slide, which I want to give you just a small diagram which illustrates the transmission cycle of the disease. Of course, we know the disease falls in those classes of diseases which we call zoonotic. This basically means these are diseases which are transmissible between animals and humans. And usually for Rift Valley fever, it's a disease which you find it in animals, mainly livestock. And it's transmitted by mosquitoes. So what happens is when an infected animal with a virus which causes the disease is bitten by a mosquito, the mosquito will pick that virus. And there's a high chance that the mosquito will come and also feed on humans. And in the process, they transmit the virus to us. So basically, that's what we mean basically by a zoonotic disease. The disease is also found in places which are heavily flooded. Usually it occurs during the wet periods because of the high population of mosquitoes which develop following heavy rainfalls. One of the major losses we see when we get that disease is a socioeconomic burden because of, we usually close markets, we usually stop animal slaughtering, we stop export of animals. So in many countries in the region, they really suffer huge economic losses. Of course, on top of the infections which happen in humans, which usually either results in febrile infection or a few proportion of people will die from infection. So let's go to the next slide, which It's just a summary of how do we use One Health for in Rift Valley fever. And I have 3 examples. The first one, of course, is as researchers, we use One Health to gain a deeper understanding of the factors which cause the disease, and also factors which cause the disease to be transmitted or to spread from one area to another. So because the disease really involves mosquitoes, it requires us to understand climate patterns. It involves a trade because of animal movement. We need people from multiple sectors to work together to understand how do these various processes, factors come together to enhance Rift Valley fever occurrence and transmission. The next is engaging communities, and as we have said, in surveillance and control, and that's what we will come back to in a short while. I want just to mention the third one, which basically means we need to work with policymakers in developing effective disease control policies. I mean, effective Rift Valley fever control policies. And usually, you really require departments from the health, from the trade, from animal health sector to work together to implement and find resources to drive those policies. And that's one other area in which One Health is heavily required. So in the next 2 slides, I'll focus on the second component, which I ask you to move to the next one. Next, yeah. And this is where we engage communities in disease surveillance. As Marisa said, it's good if we can be able to capture these diseases when they are still early in occurrence, they are still in the animal level, so that we can prevent humans. And so what we have been doing with communities is, first of all, to do what we are calling development of a disease definition, which helps us to communicate with communities. Because we cannot go there and tell them that I'm looking for disease X. You have to define what's RVF to them. And it usually means it's a disease which causes massive abortions in animals. It causes a febrile infection in humans. And so we discuss with them to come up with a disease definition, which can then be used for surveillance purposes. And in this case, for example, in Northern Kenya, we've been working with community health promoters and community from the health side and community disease reporters from the animal side, so that they sit together, they look for those cases. And we have been successful in formulating WhatsApp groups, which whenever anybody spots such a case which is defined in the disease definition, then they report and the veterinarians will then take action. Last point I wanted to make on this slide is, in addition to working on these case definitions and training communities, we also encourage them to do action at their level. This includes biosafety, biosecurity measures, which, avoiding touching animals which are showing signs of the disease, disposing animals which are already dead or the ones which are very sick, so that they can then prevent further transmission of the virus to susceptible animals. The next slide, which I want us to go to, is on control. We have vaccines which can be used to prevent the disease in animals. So all what you need to do is make the vaccines available for vaccinating animals, which is vaccinating cattle, sheep, and goats. And when we vaccinate animals, we really reduce the risk to humans, because you no longer have that source of the virus jumping over to humans. But having a vaccine is one thing. Having it used is really a challenging affair, because there are many challenges of having those vaccines reaching the communities. And in our research, we have identified several barriers which can be addressed using a One Health approach. One of the barriers is gender. In some communities, men own animals, yet women are the ones who are really very responsive to calls for vaccination. So we need to do community engagements, meetings, to really bridge that barrier between men and women. Sometimes women only can own chickens and small ruminants, while men would own camels and cattle. So you really need to get that message getting into each of the members of the community to understand that we need to vaccinate all the animals, so that we can then improve the herd immunity to reduce the disease risk. Yeah, I think there's a lot that we can talk about vaccine, but because of time, I just want to emphasize the fact that community engagement using religious leaders, community leaders, to women groups will really help us capture a bigger section of the community who can then bring animals for vaccination, so that then that vaccination campaign will be more effective in reducing the disease risk. Two main points to end the discussion is we also have been wondering on how do we really engage the environment sector. And, we've been thinking of introducing what we are calling nature-based solutions to reduce Rift Valley fever risk. This includes, reducing flooding events, cleaning our neighborhoods. But recently, we have also come to understand also that managing animal grazing patterns, especially reducing things like invasive species, will reduce that requirement for pastoralists to move very long distances for grazing. So if that movement for pasture and water can be managed, then we can reduce the dissemination of the virus in multiple locations and then reduce disease risk. Last point, of course, we need to understand the costs and benefits of interventions so that our leaders can then budget for them, make finances available, and then really roll out vaccination surveillance activities while knowing the benefits of doing all those interventions. So thanks a lot. That's my last slide, and hope to discuss with you any questions which might.
I really want you to stop, to be honest, because we're talking about a whole new way of handling and preventing diseases. And I know your last comment was, if we can control the movement of the pastoralists where they can access the grass and they can get the water, then there's a high chance of us actually increasing the prevention aspect of it. But now we're faced with climate change, and it looks like they literally have to be moving. So then that means the diseases are also on the move. How are we tackling that? Because we're still up, and I've seen a lot of communities and CSOs, especially international organizations, calling out for climate change and health not to be separated. They're very much interlinked. What are your thoughts around that ongoing deliberation?
Oh yeah, I think let me clarify what I meant. We can't stop pastoralists from moving. They'll still move because that's part of their life. What we mean is if we manage our ecosystems, manage grazing management. Actually, we have a project which we are calling participatory rangeland management, where you manage stocking rates, for example. You manage, there are so many invasive species like prosopis, which is really taking over our grazing lands. And so the available forages are reducing by the day, so that if communities can then find these grazing resources within their reach, not really moving so far, but you can still move, but within a managed system, then you will reduce what we see now, where you find people from the far end of the country moving their animals in trucks, actually in lorries, to another location just to graze them and then bring them back to their homeland when maybe drought has ended. So to cut the whole story short, it's basically managing resources that you have with the right stocking densities so that we don't really have to move so far at the end of the day.
At the end of the day. And I like the fact that you've even stopped at resources, and I'm going to call out to Marisa. But I know when Marisa was making her presentation, it's all about involving communities. We're looking at a preventative aspect, and that could actually cost us a lot of money so that we wouldn't have to, get into pandemic preparedness and now response aspect, which is very costly. And I know it's crucial, especially when you're dealing with communities that gender plays a key role, culture plays a key role. There's that whole aspect of cost management, even though we're looking at the preventive aspect. How is ILRI looking at that money aspect of the preventative side? Is it you pumping it directly? Are you working with other partners? I mean, because I know we also do have donors who join our calls. And it would be good just to know how that cost angle comes into play.
Right. I think it's also a very complex area. We really want to work with private sector because at the end of the day, you can't cover all the costs of controlling a disease. And what we have done, let me first say the private sector really works very well in high potential areas. You know, these are areas with very good dairy animals they can afford. But the challenge is in pastoral areas where the areas is expansive, the infrastructure is very poor. So our attempt has been to develop innovations where you can create local demand by aiming to reach animals, maybe when they are doing watering, that's when you can get a large population of animals, or when they move to a given location. So it's actually calling a bundling services where you can still enable a private sector delivery agents to get to communities and recoup their costs of investment. That's the main challenge that we still see in those locations.
Perfect. Perfect, good. Marisa, over to you before we go to the next. And I've seen also the chats now live and ongoing. So over to you, Marisa.
Very quickly, I just wanted to say that you're absolutely right. Climate change and health are connected and should not be disconnected. This is part of the One Health approach. Climate change is impacting the health of the environment, and the environment is part of the One Health consideration. And we see that happening in fundings, and so that is linking nicely with fundings as well, is that the role of donors is key. The problem is that donors, like everybody else, and including ourselves before, and the different organizations are organized in silo. So they would fund agricultural innovations, they will fund health innovation, they will fund issues on climate change, and everything is separated. So we're working with them to ensure that we can move away from the silo and really fund the One Health approach altogether. And also working with them to ensuring that they coordinate what they are funding. So we build on existing initiative, we build on what is already being funded. And with Presod, what we're doing is before we start any activities, we make sure we do a roadmap with all the stakeholders, all the participants, including donors, and we highlight activities that are missing to reach out the impacts, and we can fund these activities which are the missing pieces and missing chains. So donors play a very key role, and Presod can advocate at this level, and we are pushing this.
Yeah, definitely. I completely agree with you. I know we have a question for you, Bernard, on the chat from Peter. Thank you, Peter, for that question. So he's asking, involvement of communities involve creating a frontline human resource, and we have them as community health workers, paralegals, but we don't hear paravets anymore. Interesting. I didn't even know that existed. How then do you reach communities, Bernard?
We have community health promoters, basically, as what you have said. We also, on the animal health side, we also have community disease reporters. I know the government stopped, employing paravets a few years ago, and there have been various players who are coming to fill that gap. There are some institutions who are now training diploma and other middle-level professionals. And so that's a gap that we are still addressing. But as I said, many other players are coming into play through various NGOs and also government. Even the county system of government in Kenya, I'm not talking, I don't know about many other countries what really is happening, but in Kenya, this county system of government is also helping to reach out to the local areas.
Great. Thank you, Bernard. Please do stay on the line. I'm pretty sure there will be more questions as we open the overall Q&A later on. But yes, thank you, Domitila Nyango. Yes, we cannot separate climate change and health. Ladies and gentlemen, we'll get into the third presentation. We've spoken about One Health approach, and we've been given a bit of background on that by Marisa. And now we've just spoken about Rift Valley Fever. It was a case study from Kenya and what they're doing. Let's move to the southern bit of the continent, and we're looking at One Health in Zambia, community involvement to fight anthrax. It's good to give case studies so that we can relate to what is going on. So we'll go to the next slide, please. And I'm going to call out to Musa. Musa, I saw you earlier on the call. Next slide, please. Just if you click enter, there should be some writings. Perfect. Do another enter. Yeah, so that we can get Musa's perfect. That's thank you. Musa, are you on the call still? Just
yes, I'm very much on the call.
Great.
Thank
There
you.
you are.
Thank
Perfect.
you.
Over to you, Musa.
Thank you. So today I will give you, it's a story, but a very nice story. Not very nice because we're talking about a disease. This is a zoonotic disease, also known as classical zoonotic disease, anthrax. One thing I need to say about zoonotic diseases, especially those which have ended up being pandemics, is that all pandemics are already existing, and we know the causative agents, the pandemics. So what usually happens is that something triggers these pandemics. Now let us look at the story of anthrax in Zambia, looking at the One Health angle. Next slide, please. So this is the story of anthrax in Zambia. One thing is that anthrax is an endemic disease in Zambia, which means that by endemicity, which is endemic, this disease is predictable. We even know the regions where this disease usually occurs. However, when it occurs, it leaves a lot of serious public health issues, disruption in ecosystem services, disruption in social services. But last year, 2023 was a bit unique. Why was it unique? We had a very large scale in terms of an outbreak, both in animals and in humans. And like I've said, this is a disease which we know its boundaries, territorial borders. But last year, it broke those territorial borders. What happened is that we had more than 700 human cases. And Zambia has got 10 provinces, but in human cases, we had 9 out of the 10 provinces, which meant that 90% of the provinces had reported a human case of anthrax. However, what was a bit surprising is that only 3 provinces, 30% of the outbreaks were in domestic animals and wildlife. So we can go to the next slide. The key issue, if you look at this slide, the blue, I'll start with the blue. Those were the animal cases where you have got the blue, the Zambian map there. So if you look, there was one special area which is a deep blue in the southern part of the country. That was Siavonga. All the time, we never had any cases of anthrax outbreak in that area. The western side and the eastern side, we usually have endemic outbreaks, which means anthrax occurs like an annual event. Unfortunately, it occurred in that southern part. Now, if you look at the map on the left side, which is a reddish, pinky reddish, that is where now we had the human cases. With anthrax, there is what we call the lag effect or the lag period. Let me explain this a bit. The actual outbreaks in animals were seen around May, June in animals, but the human cases start being seen in late September, October, November. Why was that? What happened is that it was what is known as anthropological aspect. Humans were the driving factors in leading the disease from animals into the populations outside. And this is where it is key. So we can go to the next slide. Next slide. Yeah. So I just brought this pictorial evidence of the outbreak last year. We had quite a lot of animals dying. We had the buffaloes, hippos, livestock. You can see even in humans. One thing is that in humans, there are 3 forms of anthrax. The cutaneous form. If you look on the human there, she had the eschar. That is a wound which actually showed that this was a skin form of anthrax, and that was the most common. And if you look at research indicates that close to 90% of the cases are usually cutaneous. But the ones which kill are the gastrointestinal form, the stomach form, or the respiratory form. Those are usually very fatal and people die. If you look at canines, that is the lions, the dogs, you'll find that usually they just get swollen. They rarely die, but they get swollen from eating this. So we can go to the next slide. So the story continues. One Health community response. Now, with One Health, the response to anthrax in areas where there was already One Health approach was quite fast. However, where One Health was not practiced, the response was late, and this is where the problem was. Why? Because the outbreaks spiraled out of control. And let us take this from the community members' response in one of the villages. This is well captured, and he said, in our village, we suffered several cattle deaths, and we were able to eat the meat, but we didn't know that this meat also carried the disease, and it affected us in such a way that a lot of our family members, community members, ended up with the skin form of the disease. Unfortunately, a number of people who ended up with the stomach form or respiratory form died. There were deaths during this outbreak. However, what happened is that a lot of people also dried the meat, and they ended up selling it into to towns. And this is where now the human spread of anthrax ended up in 9 of the 10 provinces, spreading across the country, even in urban areas where people never kept cattle, never kept animals. They ended up with the disease. So the above scenario indicated the serious need for the adoption of a One Health integrated, what we call systems thinking approach, anchored in communities. So the key is, how do we empower, capacitate the communities in terms of community-based surveillance? How can we have intelligence groups for rapid response? Now, I want to say something about this situation. This anthrax, quite okay, it spreads beyond the territories, but the situation could have been worse. It could have been even becoming a serious pandemic, but why it didn't do that? There are what we call limiting factors. One thing is that anthrax, there were no human-to-human infections. That was a limiting factor. And then the second limiting factor is that with anthrax, it is not a contagious disease. Now, imagine if we are dealing with a contagious disease, and with the way people move, this would have spiraled out of control. We can go to the next slide to look at community engagement, because that is very key. So when we are looking at community engagement, we are looking at community members themselves. How can community members play an active and key role in these zoonotic diseases? There is what is known as rural participatory governance. I liked Bernard touched a bit on the rural participatory governance also. He touched just a bit on that one, especially for pastoralists. So what we used to have is that in those where they were able to control, there were One Health teams which were involved in the community activities, from decision-making to implementation of either monitoring, even applying the control measures. One key aspect is the strengthening of communities on how to respond, especially local adaptation and having ownership. Like I've said, the communities themselves are the ones who get affected. Disruption of ecosystem services, disruption of social services, deterioration of the environment occurs in the community. So local response mechanisms are key in order to make sure that the communities are able to prepare, to detect, to prevent, and respond to these anthrax outbreaks. Now, I will give you one scenario which was, I've seen we have got Zambian colleagues who have also joined. The carcasses which were dying and the meat which was being dried. You see, when an animal dies of anthrax, you don't open it because immediately the anthrax bacteria is exposed to the air. It sporulates. It forms a very hard surface whereby it will survive a lot of conditions, heat and all this, and it will be transported everywhere. And those spores, they can remain in the environment for over 6 days. So the contamination over 6 days in the environment. And you can imagine what has been done now by spreading the anthrax around. Now, in the community, when we were doing, because I do a lot of research, there was a special group of people. And this special group were the children, school children. The school children were the ones who were informing the veterinary officials, health officials, and the police that such a truck came last night in such a village, and they were packing dried meat, which we suspect is meat from animals which were dying from that disease. And the police, they would tell their colleagues, can you check for such a truck? And they were able to confiscate that meat. And that was a key intelligence information from kids, children. And some of them started hiding because there is what is known as a mining area, which mines coal in Sinazongo area where we had the West outbreak. They started putting coal on top and the sacks of meat below. And the children informed the police and they were able to intervene in this. So that is the power of the community. So if you look at the community, so you cannot overemphasize how the community responded, how they engaged themselves, and how they shared this key information. And it is this key information which led to the halting of all these spread. And that was key. Next is the slide. So the last slide just to show an overall action we did with the anthrax. We had the awareness rising through electronic medias, the television, and here we had also community engagement. There was also physical community engagement right in the affected hotspots. Then the Zambia National Public Health brought all the actors, including the community, in order, what was known as a multi-sectoral anthrax coordination mechanisms to try and halt. And apart from that, we had also multi-sectoral partners, and you can see we have the WHO, we had the PRESOD, which I was representing also with my colleagues, COHISA, we had the Zambia National Public Health, and a lot of other activities, USAID, IRI, being represented by our partners in Zambia. So we were able to respond to this. So this story was quite successful, but like I've said, these are pandemics which have got a probability of coming back again. So we need to be better prepared. Basically, this is the Zambian story which I wanted to share in terms of the One Health approach. Thank you very much, Liz.
Thank you. And thank you very much for making it such a story. I could tell I was actually, reliving it. But before
Absolutely.
you go, yeah. So thank you very much, Musa, for that. I like the way you just narrowed it down. This epidemics can come back if we do not take care of,
Exactly.
like,
Yes.
tighten out those loose ends. It would be good just to see whether there's something that came out that was more of, a learning phase or something that you're doing in the country that is trying to not take you back to where it was, because ideally for them to come back, we need to make sure that we've put, in Kiswahili we say mikakati, things in place that are going to take care of it coming back. And we've, like Ebola, where we're dealing with Mpox right now. It's been there for quite some time, but it's fully blown. But if
Exactly.
what would be that learning factor or something that Zambia is doing that we could actually from the other countries also pick up?
Thank you. One key learning factor, you see, these outbreaks occur in communities. And we even have information. So there is need for what we call real-time reporting. And real-time reporting, if you saw on that video which Marisa presented under prison, if there is no real-time reporting, and one thing we have seen, and it came out very clearly from this outbreak, the lag effect, where you have the disease occurring in animals, and in humans there is nothing. But because of what is known as anthropological activities, human activities, they will be able to trigger something more serious. Like I've said, that we are fortunate that anthrax does not go from human to human and it's not contagious. If it was a disease which was contagious, we would have been talking of something beyond. It could have even reached a pandemic proportion, because pandemicity or pandemic level is just a global, multi-country involvement, multi-continent involvement. But this was localized within our country. So those are some of the key issues which were key learning outcomes. And we shouldn't underrate also what we saw, the children, the school children, because most we talk of youths and maybe women groups and the general community, we talk of adults in terms of community-led monitoring and responses. We don't talk about school children. We have learned that school children can actually play a very critical role. Absolutely.
Great, thank you, Muso. And I'm going to, ladies and gentlemen, I'm usually very selfish. I need to learn how to share. We've gotten to the point of Q&A, and this is why you ask all the questions to all the speakers that spoke. So we have Marisa, who gave us the One Health definition. Then we have Bernard Bett, who brought in the Rift Valley fever, so a case study from Kenya. And we just had an amazing story on from Zambia, from Muso. And we're opening the floor to Q&A. And of course, before I call Peter Owiti, I'd like to bring in Marisa. The fact that we're talking about surveillance, it's very crucial and it's key when we're talking about prevalence. And from Muso's story, they even got the communities to, report on incidences that were very suspicious and people who were trying to export the meat. In terms of surveillance, when we talk about One Health, we still look at it from a broader perspective and ignore the role that communities play. What would be your input around that before I call out to Peter?
Yes, so I would like to add that you have been working a lot with the communities and the Global Fund on tackling a specific issue like malaria, HIV, tuberculosis. The people that are facing malaria, HIV, tuberculosis are the same that relies on agricultural and wildlife and on environment for their livelihoods. They are the same people that are facing emergence of disease on an everyday basis. So basically working as a One Health in this issue is acknowledging that those community, they rely on animals for food, on environment for agriculture, and they have health issues, whether they are human diseases or potential spillover and spread from animals. So we have to work all together and acknowledging that and making sure that in the field they can identify quickly, as Muso and Bernard mentioned, any potential suspicious signs. So that means working the vets, the health specialists, and the environment. They also need to work together to be able to support the community for that, to be able to identify suspicions from animals, from environment, and react quickly. And the reaction is also one big issue, because what happens often is that governments want only professional and technical experts after being informed of something is happening to react. But community needs to have tools to be able to react quickly if we really want to stop any spread. And that has to be done in transparency with the technical agents as well. So this is One Health.
For sure. Peter, over to you before we read out some questions, some interesting questions that are coming in.
Yeah, thank you. Can you hear me?
Loud and clear, carry on.
Hello, can you hear me?
Yes, loud
Yeah,
and
thank you
clear.
very much. I wanted to ask Dr. Cheret about we have copied some laws that are difficult for us to manage in Africa. In this era where pathogens are zoonotically spread, we are the Kenya government passed a law that we don't get rid of those mongrels. I mean, those dogs that keep on roaming around, spreading diseases to human beings. So the dogs are increasing, spreading diseases, and yet the dog lovers and the law says you cannot get rid of them. And these days we no longer even poison them like we used to do. So what are we going to do? What are we measures? But here spreading diseases, that's the concern.
We're losing him, but I think we've got the gist of the question. I think that was directed. Is it? Sorry, Peter, your connection is a bit unstable. Yes. We'll take another question, and I've seen.
Did you get me? I was talking about the mongrels, the dog.
Yes, yes, we got the question.
Did you get me?
Yes, we got the question.
Okay.
Perfect. Thank you, Peter. And there's also another question that came in. How do we ensure real-time reporting on the grassroots? How do we ensure that is happening? And Muso, I'll let you handle that question once we get Bernard to tackle the issue that has been raised by Peter Owiti on how do we take care of the mongrel spread. We cannot go on killing them the old school way, the way we were doing it back then. So Bernard, over to you, and then we'll get Muso to respond.
Yes, I agree with Peter. I think it's a menace that's increasing. You know, rabies, which the dogs are spreading, is becoming a major issue in the country. The regulation that was put out was the use of strychnine. It was a poisonous product, which also contaminates the environment, and also it's quite, from the animal welfare perspectives, we couldn't continue using it. So there are other humane ways in which you can cull such animals. Some people actually advocating for neutering. That's you reduce their ability to breed by either doing castration, or in female dogs you can remove the reproductive the uterus and other and ovaries. But there is a vaccine for rabies, so we can use the vaccine. It's quite available. It can be used very efficiently. One other thing we could do is, you know, rabies now is becoming more rampant in very urban areas where there's a lot of dumping, you know, dumping grounds where, you know, these dogs come and breed, they get food, they get, you know, feeding on the waste. So if we were to manage the environmental, you know, we clean the environment properly so that we can reduce kind of, you know, them coming in large numbers in those locations, and making sure that we have the vaccine, then I think those are the immediate things which we could do on our side to reduce rabies menace.
Great, thank you, Bernard, for that. Mosa, if you're there, we're looking at how to ensure real-time reporting, especially on at the grassroots level.
Thank you. Thank you. Yes, I'm very much here. So with regards to real-time reporting, if you look at communities, this is one of the things, if you look when I was making the presentation, the need to build the capacity. Once there is a capacity, because they need to know that anything abnormal, like what that video Marisa showed, when you have something abnormal occurring, there is need to report. And once, like I've said, is that the community themselves should be the ones who take charge. Because if the community themselves are not able to see and analyze that this is unusual, an animal has died, like what one of the community members said, it took them maybe 3 weeks for them to even report anywhere. So we were raising awareness that immediately an animal dies, even one, especially where you see signs is blood is coming from the mouth, it's coming from all the ears, the nose, you need to immediately report. So those are issues which the community have been told that there is what is known as real time. As it is occurring, you report both to the local, because there's what we call, in Zambia, there are two types of leadership, the traditional leadership and the political leadership. So those in the villages, they can report to their chiefs or the headmen, and once you report to this, they take it up very fast, or to the area member of parliament. That's the political leadership. These usually, once they instigate the government offices, you find that the response is very fast, I can assure you. You find that the response which they will get, so it's part of the real-time reporting, because you need to understand the community structures, the community, I can put in inverted commas, community organograms. There are certain leadership styles which, once they are instigated, the response from central government is very fast. So those are some of the real-time reporting which we are trying to impart, and also ensure that the community, they are very active. They take an active role in terms of data collection, just looking at what they see, because they are the ones who get affected. So they need to be proactive. It's part of the training and awareness which we are doing, part as Present and the Cohesa. Thank you.
Thank you very much, Muso. Marisa, we have a question from Gesonko, but I know John Lorot, your hand was up. I don't know whether you still have the question you'd want to ask. Feel free to unmute yourself. John Lorot.
Yes, thank you, Lizzie. Good afternoon, good evening, everyone. Yeah, actually, I'd raised my question. I'd put it on Q&A. I don't know whether you had seen it, Lizzie.
Not yet, but please feel free to just ask.
So I think my question goes to Bernard. Yeah, this one, I come from Uganda, and specifically, I come from Karamoja region, and you know Karamoja region is one of the pastoralist communities, and it's along the border between Kenya and Uganda. And in most cases, being a pastoralist community, we have seen, pastoralists cross over from Kenya, the Turkana, cross over to Uganda. From this other side, we also cross the other side, which I see in some cases, of course, in case of any pandemic outbreak, definitely both sides will be affected. So I don't know whether, to Bernard, I don't know whether we have any mitigation strategies in place that probably you have in plan to, or there's something that you're really doing to address some of this area. Thank you, and over to you.
Thank you very much for that question. And I know very well we do have some questions that are being put on the Q&A, and thank you very much, colleagues, for just making sure that you're also tackling those questions. So Bennett, before we go to you responding to that, this one I think I'll direct to Marisa. So after Bernard comes in, what are the opportunities in terms of technical assistance, capacity building, assistance strengthening to local networks and community-led organization that works with communities residing or highly interacting with animals? So that's from Gesonko. Thank you, Gesonko. And I'll let Marisa respond to that. So over to you, Bernard. Thanks.
Yeah, thanks, John. There are so many cross-border locations which now people are focusing on. Even in addition to the one you mentioned, we have others like in southern part of Kenya, in northern part of Kenya with Ethiopia. And people are now realizing that, diseases have their own ecologies, and these ecologies don't really recognize international boundaries. So we are dealing these diseases using what we are calling epizones, so that we then engage communities on both sides of the border and do like joint vaccinations, do community engagements, trainings. And one major challenge actually that we realize with that is each community on each side of the border would use their vaccines from their own countries. And usually those vaccines may not be of the same manufacturer. They could be of the different efficacies. And those are the challenges which we need to address at those border points. ILRI finished a project 2 years ago, which was looking at PPR. That's one of the diseases of small ruminants, for those who don't know. They were doing a joint vaccination and education across borders. And currently, I don't really think we have an active project. But as I said, we are now realizing that we need to work much more across these borders. And in future, of course, I know we'll be developing projects on those. We have ongoing projects in northern parts of Kenya, looking at Ethiopia and Kenya, and southern parts looking at Tanzania and Kenya. So let me stop there and say, yeah, it's a very good point.
Yeah, great, thank you.
Hello. Hello. This
hi,
is Richard Mahulo
over to you, Richard.
from Busia, Kenya Long Distance Truck Drivers and Allied Workers Union. My question is, how are you going to incorporate these long distance truck drivers in the project?
Perfect.
Thank you.
Good question, and we don't want to leave anybody behind. So Marisa, when you're responding to, I know you've tackled the question that Gesoko had put on the chat. Maybe it would be good to also take this one from Richard right now before we call out to Karina.
Yes, sure. I just wanted to apologize because I can only see the chat, not the Q&A, so I'm responding in the chat. I apologize for that. Just to make sure, can you repeat your questions because I could not hear all of it.
Oh, okay. So Richard is asking, how are you working with long distance truck drivers in the whole One Health aspect?
That's a very interesting question. So what we are working on is movement of animals, movement of humans, to see what are the risks of these different kind of movements in the spread and emergence of diseases. So we are including them when we work in a specific area on the case studies. We are looking at all these factors. So what are the factors that can promote emergence and spread and movements of both animals and humans, and including with trucks or including with pastoralism or things like that, are considered in the assessment. And you're right, this is a very important aspect. We've seen with avian influenza that the virus would last for long, even in the truck without animals, if it's not cleaned properly and disinfected properly, and can still spread to other farms or other area. I hope I'm answering the question.
Thank you. I saw Karina's hand up. Karina, are you still there? We do have 4 minutes before we close down. And thank you very much, ladies and gentlemen, for just being on the call. We had over 70 people on the call. We still have 67, so this is great news. Karina, over to you.
Thank you. Thank you very much, Lizzie. I just added in the chat that I understand ENASO did a learning assessment at the beginning of the year, and one of the things that people were interested in is how to get access to funding and technical assistance on One Health and pandemic prevention. So this is your opportunity, colleagues, to tell us if this is relevant and if we should organize this second webinar on access to technical assistance. That's it for me. And yeah, I really want to make sure that we have an opportunity to engage beyond this webinar. So I posted our contact details. And maybe one thing that I want to add is that PRESOD has also this role of connecting science, society, and policy together. And I think this is something important that we may want to work on together. Thank you.
Thank you, Karine. Marisa, I've seen your hand up.
No, just quickly to build up on that, we would be very happy to discuss further with the people interested to work on how we can assist you and provide technical assistance. We are already doing it in different countries with different partners. We can work on training materials. We can work on methodology on how to reach the community, looking at what needs to be considered. And I go back to the truck driver question, for example, like looking at all the different elements. So we would be very happy to engage more with you, definitely. Thank you.
Oh, yes. Yes, thank you very much. For all the speakers that just spoke, I'm sorry, Larry, I saw your question, but it must have slipped my hand. So Larry Simiyu is asking, how can you engage the people living with disabilities in disease surveillance and prevention? I don't know who wants to take that, Marisa, Bernard, or Musa.
You mean, if I heard the question right, people with disabilities, is that right?
Yes.
So I also answered a similar question about how to engage with the drug users. So at the moment, what we've been working a lot is working with communities that are based in agricultural practices or forest and everything. But the thing is that it is very important to take into consideration all these vulnerable communities. And we haven't got a lot of experience with that because this is not what we've really focused on. But definitely the work we're doing, the material we have can be adapted. We're working with journalists, we're working with different type of people. So working with you to be able to understand what are the constraints and the needs of these specific communities, and then we could engage them better in the prevention of emerging risk as well by building specific and adapted tools and awareness material. Absolutely.
That is perfect. And yes, Naomi, thank you very much for highlighting that we need to frequently have these discussions, and that's what we're going to be doing. And that's why we appreciate the partners together with ENASO in just organizing this particular webinar. Ladies and gentlemen, we've come to the end of this particular session, and we'd like to extend our appreciation to the partners. And of course, we want to collaborate and we want to have more country-specific discussions. So please feel free to also reach out. What we'll do later on, we'll share the recording and the PowerPoint presentations that were made today. We'll also share contact details. I know, Karine, you posted that for all the speakers. Maybe reshare that again so that you can reach out to them and you can, start one-on-one discussions. Prezod, CIRAD, I and ENASO are more than happy to explore areas of collaboration and having more tailor-made discussion, talking about country-specific experiences around community engagement when it comes to pandemics, when it comes to the One Health aspect. So thank you very much. I know we've run out of time. And what I'd like to say is the role that communities play is crucial. And if we were to look at the preventative aspect of handling any sort of disease or any sort of outbreak, we have to have a bottom-up approach, which I completely agree with the Prezod team and CIRAD's team on that. And we need to have communities at the center of all these deliberations. Thank you very much once again, ladies and gentlemen, for joining in. Thank you, partners. Thank you, speakers. It was lovely having you here for 1.5 hours. Looking forward for more discussions and more fruitful engagements. And thank you, partners and also delegates who joined in. Appreciate for you sparing your 1.5 hour. Have a great morning, great afternoon, and great evening, wherever you joined in from. Asante sana. Goodbye.
Thank you very much, Liz.
Thank you very much.
Thank you. Bye.
Goodbye, everyone.
Thank you.
Bye-bye.
Goodbye.
Bye. Thank you so much.
Thank you.
Thank you. Bye.
Bye-bye.
Thank you.